I have a couple of disclaimers to make. First of all, that I am a psychiatrist, and so a lot of what's going to influence what I say will be seen through the limitations of that lens. And so you'll forgive me when you hear that, because I understand that most of you are not psychiatrists in the room. And I'll try to live with that deficit that I have. I also have trepidation because I feel somewhat underdressed to be figurative in my speech, in that I don't have a PowerPoint presentation. We were discouraged from doing that by our leaders, and I think it's a good thing. I think it's the right thing. But I'm so used to having a PowerPoint to protect me, and I don't have that today. And I tried so hard to create a TED Talk like John Spertus. And I worked on it, and I just couldn't come up with the TED Talk. But you got a great example just ahead of me. At least when I was introducing John in Beijing a year and a half ago, all I had to do was introduce him. This time I have to follow him, so that's a little bit tough. I'm going to talk about the trepidation, first of all, that when John Carney called me up and asked me to talk about this topic, it was actually John's term, the dissonance, and I have not done any specific research on that. And it was John's topic, and I think it's an important and a good one, and I was willing to address it, but I have trepidation for a number of reasons that I'll explain. First of all, the false assumption that the general public has is that psychiatrists can read minds or at least analyze on their feet, so to speak. I remember when I was in training as a resident, one of the kids in the neighborhood came up to me one day and said, "Would you read my mind for me?" And I had to explain to him that we didn't do that, and we're not very good at it. And in fact, we're not very good even at predicting future behavior. So we have to be humble about our capacity. I think most psychiatrists are as clueless as the next person about what's going on inside of somebody's brain. Another false assumption, which is that psychiatrists always know what to say. There are many times that I'm completely at a loss for what to say, particularly when a friend or a family member is experiencing a loss. And I've toyed with lots of responses, and all of them seem to fall short or to imply the wrong message or to be inadequate. The only response that I have come up with that tends to satisfy me anyway is to say to the person, "I'm thinking of you." And the false assumption is that psychiatrists somehow know better how to say things than other clinicians do, and that's certainly false. I think one of the most effective examples that I had was in my training with the chief resident of surgery. He would walk into patients' rooms on rounds, often with only 2 words to start with: "No cancer." That's what the patient wanted to hear, and if it was the case, he needed to get right to it. That was one of the more empathic, that's a great example of an empathic intervention in my mind from a surgeon. Another false assumption is that clinicians know how to listen. Often the most helpful thing we can do as clinicians is to listen. But if there's one failure that I see in trainees in healthcare, so they talk too much. And they talk too soon. One study did show that the average length of time that it took clinicians in an outpatient clinic to interrupt the patient after the first initial leading question, it took an average of 18 seconds before the physician interrupted. And in my field, psychotherapy is obviously one of our tools. And psychotherapy historically acquired the title the talking cure. it's often not a cure, but it really should be relabeled the listening cure, because effective psychotherapy is more about listening than talking. One of the most difficult things that I faced as a trainer, as an medical educator, is convincing medical students, residents, and other trainees that listening to a patient tell their story is therapeutic. Even better if somehow the patient can feel understood. There is a place for directive questions. By directive questions, I mean questions like, when did it start, how much, how often, what color? But there's also a very important place for open-ended questions and then getting out of the way. By an open-ended question, for example, tell me about your family. What was happening in your life when this first started to bother you? I'll give an example of that from personal experience. I experienced a sudden onset of unilateral flank pain. Most of the clinicians in the room know that was my first kidney stone. And I had somebody able to drive me to the nearest emergency room, and as I dragged myself along and entered, you can imagine that the triage nurse greeted me and said, "Tell me about your family." No triage nurse would ever do that. And what she did say was, when did it start? How often? Have you ever had it before? What medication are you on? That was the most empathic intervention she could have made. So I'm not putting a value judgment on close-ended directive questions versus open-ended questions. I'm only saying that if there is a slow day in the clinic and there is a patient who you want to understand in a different way, consider a question like, tell me about your family. And then get out of the way and listen. One of the techniques that I have found useful, and it's not my brainchild, it's been commonly used by many people. I don't remember who modeled it first for me, but it's a wonderful technique I find, is after the initial conversation with a patient is to ask if it would be all right to repeat back a summary of what I heard and allow the patient to do the editing. Because you may have gotten some of the facts wrong, but at least you convey that you were listening and you were trying to understand. And you may get a more accurate set of information after it's all said and done. The patient may edit second time around as well. But my most important gratitude goes to my son, who taught me a very important lesson about listening. During one of our conversations when he was about 6 years old, there was a disagreement, and I guess he felt that he wasn't being heard. And his comment to me was, "Dad, you need to get a bigger pair of ears." A colleague of mine fairly recently conducted an exercise with simulated patients. You understand that we can protect some patients from trainees by simulating, by paying actors and actresses to simulate the role of, and we do at UMKC. It's a very vibrant part of what we do. My colleague is a psychologist, and he teaches a course, and he was observing students interviewing simulated patients, and he talked to me about the struggles they had. One of them was simulating anorexia nervosa. And one of the students said, "I don't know how to deal with this patient." Now, at least that's an honest response. If you do feel that, if you can recognize it, that's a good thing. Other students were arrogant, others were paternalistic. One, in fact, almost said as much as, "I will tell you what to do and you'll do it." Another clutched her clipboard throughout the entire interview as sort of a shield. But some students performed very well. And there's hope for all. My interpretation was, as a typical psychiatrist, was to say that many of the young trainees and old clinicians are alexithymic. Now, that's a complicated word, but it means alexithymia, no words for the feelings. That we clinicians often struggle to describe our own feelings as well as to recognize feelings in our patients. My colleague had a more favorable, generous interpretation. His understanding was that under stress, under duress, these students were resorting to the science as a protective mechanism. And I think he's probably on target as well. So having talked about the false assumptions that I bring to this, or at least present to you, I'm going to tell you about a few truths that I think that I've stumbled upon over time. One is that everyone brings bias into the clinical encounter. The patient, the clinician, everybody brings their own biases. Everybody brings their own agenda. Let's take the example of the patient who comes in with pain. Perhaps a patient with pain is feeling, "I want relief, I want to get well, I want the doctor to respect me as a person." Perhaps the clinician is thinking, "How can I be most helpful?" Or the clinician may be thinking, "Will I promote addiction? Will I get into trouble with regulatory boards? Will I be sued? How late will I get out of clinic today?" There are all of these personal agendas that everyone brings to the encounter. And it's not that one's personal agenda or one's personal perception is necessarily a problem. What's important is to try hard to recognize it. No clinician is required to love their patients. And in fact, loving your patient too much can present a problem, particularly if you don't recognize it. It doesn't mean you're a bad clinician if you hate your patient. It's going to happen sooner or later. What's the problem is if you don't recognize it. Don't pay attention to it, which will help you to avoid acting out the feelings that you have, either positive or negative. By definition, an emotion cannot be controlled. It's a spontaneous eruption. It's part of being human. What we can control is our attitude, and I think Aretha Franklin taught us how to spell it. R-E-S-P-E-C-T. That's what we can control. That's what we can do something about. And it's really the only part of it that we're responsible for, not how we feel about the patient. We're responsible to examine how we feel, but to treat every patient. And I would even go further. The degree of respect that we show our patient should roughly be about the same in all cases, not one patient more than another. There should be a certain level of respect, the utmost respect that we bring. And then language, the final truth that language is different for everybody. And that's really, in a sense, what I was assigned to talk about. But I tell my medical students that they are going to need to be linguists. They're going to need to speak at least 2 languages. It's great if they can speak another language, such as Spanish or French or German, to be helpful to their patients, but Sudanese. But it's not absolutely required. But there are 2 languages that they have to speak. In their training, they're learning to speak the language of science, which has the advantage of precision and communicating, to a certain extent, exactly what we want to communicate without saying more or less. And I want our young trainees to learn the language of science and to use it in their conversations with their fellow scientists, clinicians. But I don't want them to give up the street language that they learned growing up. Because the street language is the way they're going to communicate and listen to and understand their patients. So they have to have at least those two languages. The street language of one person is different from the street language of another person, but I think you know what I'm talking about. Is my time? Okay. So I think I'll stop right there.